repeated the CBC, so then they decided to do the bone marrow biopsy, and then they found it. But it's early. So all they're doing to me is making me go to the doctor every month, getting a blood test, checking my platelet count. It dropped a little bit, so I'm fine for 3 weeks, then I go back again, and then, it dropped 2 more points. Nothing we could do, just 3 to 5 years, you have to have a transplant. My sisters don't match, and is there anything I could do except just fear every month, waiting for the stupid blood test, it dropped a little bit, I'm fine for 3 weeks, and I know I have to have it next week again. I don't know. I'm just frustrated. I don't have enough information on it between MDS, is it leukemia? They don't want to get me to get to the leukemia part. I don't know.
I'm sorry, you sound frustrated. I see what we can do. As any other disorders, MDS is many diseases. So it's important to know which specific category you are in, meaning are we looking at another 20 years of just blood transfusions and possibly some gentle experimental therapy to improve your counts? Or are we looking at the evil disease that have a high chance of transformation to acute leukemia? So that's the first very important question. There are drugs. There are 3 FDA-approved drugs that are available for treatment of myelodysplastic syndrome, and one is known to improve survival and defer the transformation to acute leukemia, and one is very good for a specific subtype of myelodysplastic syndrome and improves your red count. But it's important to know the little details of the information before giving any kind of recommendation. So.
Right now, all she says is we just have to watch it.
Well, do you know the chromosomes? Which are chromosomes are abnormal?
6.
Chromosome 6.
Yeah.
That's not very common. I don't know, that's probably going to sound very wrong, but I think any of us would be very happy to see you in the clinic and have a conversations that are pertinent specifically to you.
Yeah.
Blood counts. What are your blood counts exactly?
Last month my plate was for 83.
Oh, what about the other counts? White count and hemoglobin?
White count was 3.8.
And the red count?
Red count.
So you have not been needing any transfusions yet?
Nothing. This is all like they caught it in a fluke. She says I'm early stage, and just watch. But 3 to 5 years, if you don't have the transplant, you're gonna die.
Oh, that's great. Given the die part, I think that's always that's the fun part.
This is my dog.
I think your case is very common, this kind of presentation. I think it is really important to have very good review of your slides, of your bone marrow biopsy, by a very experienced hematopathologist, because that can really make a difference in terms of helping to predict which direction, as Olga said, your disease is likely to go. Some of these diseases don't need treatment for many years, or some of them do need treatment very immediately.
So
transplant is a curative option for your disease, but of course the risk and the benefit of the transplant has to be carefully reviewed with you, and some of the treatment might be needed prior to a transplant if that's what you need. So I do think it's crucial. I always think it's a good idea when you have a difficult disease like myelodysplastic syndrome to at least get an opinion about the biopsy that you've had, the pathology that was obtained during that bone marrow exam, and then to discuss treatment options. As Olga said, there are 3 approved drugs. There are other studies ongoing for myelodysplasia. It's an area hotly investigated at the moment in terms of what we can do that's novel. And transplant is a curative option. You look to be in perfect condition. So I think that these are things that you can do instead of having that anxiety. You can start to plan a little bit by getting an opinion from a center that does transplant and that does experimental trials in myelodysplasia.
Okay, so first of all, myelodysplasia is not necessarily a death sentence in a short period of time. It is a disease that some patients may live 10+ years and have relatively stable counts. So I think the notion of watching and waiting, if you will, is not totally off base. Again, like anything else, knowledge is everything, and having a thorough evaluation and knowing exactly where you stand, that's clear in your mind, is something that's going to give you peace of mind, and is something that you should avail yourself of. That being said, from the standpoint of myelodysplasia, there are several risk factor analyses that we do on every patient. There are a variety of factors that we look at, whether patients are getting transfused, what their bone marrow chromosomes show, how many abnormalities there are in their blood count, and what the percentage of abnormal or blasts in the bone marrow are, whether there's fibrosis in the bone marrow. A lot of different things go into the criteria of saying this is what you have, and then those are put into a statistical model in which we can predict not only your survival, but also the chances of this transforming to acute leukemia. Now, from the transplant standpoint, we want to do transplants on patients with myelodysplasia who are not transformed to acute leukemia. Results of transplant in that scenario, it's kind of like going off a cliff and then trying to pull yourself back, are very problematic, and the survivals are not great. If you can do it before that develops, at a time when, gee, it looks like it's going to happen here really soon, that's the ideal time, because it's a risk-benefit ratio that we deal with. And in general, we say if a patient's got about a 2-year survival or less, that's the time for a transplant. If you're going to live 5, 7, 8 years, then it's way too early for transplant. But again, as I mentioned before, in patients like you, we like to know what your options are. You said your siblings don't match. But what is your HLA type? What is the possibility of finding a donor for you relatively quickly if things change quickly? And has that been kind of worked out in not only the doctor's mind, but your mind, so that you have, if you will, an algorithm in your mind to say, this is where I am now, this is what they're monitoring, and this is what's going to happen. Unfortunately, sometimes in patients like you, we do too many blood counts, and it's usually patients are anxious for anywhere from a day to a week to 2 weeks before they get their blood tests. Everything is stable, I'm feeling better now, and then 2 weeks later you go through the same torture all over again. So we try to minimize that, especially if it doesn't look like things are changing, and in general, every 3 months is probably appropriate in most patients. The thing that people worry about in a patient like you with lower platelet counts are that you can transfuse red cells. That's not a problem. If you get anemic, we can give you blood and keep you alive for years. Platelet transfusions are a little bit more problematic. They last for a much shorter period of time, so we don't like to see patients get down to very dangerous levels of platelets, because then the risk of bleeding goes up. And so we like to head those patients off at the pass. So that's, again, something that maybe they're a little bit more concerned because of your counts are where they are right now. But at 83, you're not at major risk of having a serious bleed. And in fact, you could probably have major surgery with a platelet count of 83,000 and have no major consequences of bleeding. So it's not that dangerous in the grand scheme of things. But again, what does your bone marrow blast show? What does your bone marrow chromosome show? And whether there's fibrosis in the bone marrow, and what is the trajectory of your counts as they're dropping, all that would lead us to say, maybe it's time to try one of these drugs that are FDA approved, or we all have clinical trials for patients with low risk and high risk MDS, and maybe it's time to enter a clinical trial even now with a platelet count of 83,000.
Thank you very much.
I just want to mention one point. There are several diseases in oncology, like MDS, where you make a diagnosis, and that doesn't mean that you need treatment. In fact, based on some of the participants here, I'm sure you'll hear about other diseases like chronic lymphocytic leukemia or low-grade non-Hodgkin's lymphoma. These are all diseases where you make a diagnosis, that doesn't mean you need to treat right away. And the main reason is because treatment can have more side effects than the disease itself. So, as Dr. Steve, Dr. Stock, and all the participant has mentioned, I think it is important to find out what is the status of your disease, number one. Not just the diagnosis of MDS, what is the risk group you are in, and that will determine how often you should be followed up. What are the tests other than the stupid blood tests you mentioned? There are other things that may need to be followed up too. Apart from the blood test. And not only that, when to intervene. So these are all determined by the risk group. And some patients, as Dr. Frankfurt said, you may not need treatment for the next 10 years, 15 years. Why subject you to treatment and its side effect when you don't need treatment? That's the principle behind all this philosophy you just heard. Okay?
Thank you.